Well, good afternoon to everyone. Hi, Maria. Hi, Rafael. Have a safe flight back to Barcelona. And so thank you very much for this invitation. Thank you to the chairs. My topic will be HBV management, mainly HBV cure and new treatments. But before I will enter into the topic of cure, let me share with you a paper that will be submitted in a couple of days from a large number of investigators. The Polaris Observatory developed a model to estimate the prevalence and the outcomes of HBV infection. And the point I'd like to make is very easy. Hepatitis B today is a major problem. It's a major problem, not in Italy probably, not in Europe probably. You see Africa, Southeast Asia, Western Pacific, more than 250 million people are S antigen positive, and the number is increasing despite a very effective vaccination. Only 36 million people have been diagnosed, only 7 million people are on antiviral therapy. And if you project in the lower part the morbidity, mortality over time, they are expecting the paper to see a progressive increase of liver-related complications, hepatocellular carcinoma, and liver-related mortality, despite an excellent vaccination, and I'll show you briefly, excellent antiviral therapy. So that's a major problem today in many countries in the world. What's about antiviral therapy? Well, antiviral therapy for the last 20 years has been very effective and very simple. One pill a day keeps the doctor and the virus away. Simple. And Entecavir monotherapy, TDF monotherapy, or TAF monotherapy is very effective, very simple, very safe. From histological point of view, is effective from the virological and also clinical. We showed an improved survival. But that's a long-term therapy, potentially lifelong, with very few patients because of the mechanism of action of the drugs that will achieve S antigen loss, the real cure of hepatitis B. And also, you will be able to reduce cancer by 50% on long-term oral therapy, but you will not be able to prevent completely. So there is still room for improvement, and the overall idea is to change the strategy. What we are doing today on the top, the goal is to improve survival, patient survival. To improve survival, we stop viremia. We don't care very much about the S antigen. It's not really linked very much to prognosis. And this is based on long-term oral therapy, long-term monotherapy. There is no resistance with these drugs. So in the future, in the future, we would like to change the strategy. The goal is to cure hepatitis B. To cure hepatitis B, we need to target S antigen and, of course, DNA. And this will be based probably on short-term combination therapies. At what we call functional cure. Functional cure is the new name of a very old endpoint, S antigen loss of therapy. And of course, there will be of therapy and associated with still integrated DNA, remember, and also probably some cccDNA, and that could be a problem. So how do we achieve functional cure in hepatitis B? The strategy is very simple. Let's try to combine a strong inhibitor of viral replication together with a strong inhibitor of viral production and together with a strong immunomodulator. That's very simple strategy, apparently, right? And of course, we don't know which is the strategy, which is the sequential way, combination, de novo, add-on, which one of these potentially 3 drugs will be the first one, which will be the second one. But that's the overall idea. And actually, we have a huge number of drugs under development for each of these categories. I don't have time to cover all these options, of course, but we'll try to review the most important for today clinical point of view. Let's start with the new drugs that are able to inhibit viral replication, and one very important candidate is CAM, or capsid assembly modulators. Many companies are working on this CAM. They have a major advantage, oral therapy, generally very well tolerated, but some CAMs have been stopped because of liver issues. On the left side, you see the mechanism of action. It prevents capsid assembly and prevents packaging of pre-genomic RNA, basically stopping viral replication. However, if you look also in the same scheme on the left, you see that the drug is not doing anything at the RNA levels, all the other small RNAs of the virus leading to S antigen production and all the other antigen production. So the drug is not able to achieve reduced S antigen or to achieve S antigen loss. So today, for functional cure, it's probably not a relevant drug. However, many companies are working on the third and fourth generation CAM, more potent. Maybe in the future, this drug will enter again in the new therapeutic strategies. Maybe in the future, they will be able to achieve S antigen loss, but not now. Well, if you cannot use a CAM or you cannot use NUC monotherapy, why don't we use siRNA? siRNA is a wonderful technology on the right-hand side. You target the RNA, the viral RNAs. By a single RNA, you might target all the antigens from the virus, including S antigen. If you stop S antigen, hopefully the immune system will recover, and the immune system will destroy the cell, and you will get functional cure. That would be potentially a very good option. Well, there are several studies, but this is the largest study ever. This has been recently published, the REEF-1 study. More than 400 patients, either NUC-naive or e-antigen positive or e-antigen negative or NUC-suppressed. You see the 4 different clinical features and groups were treated with 1 year of siRNA plus or minus CAM. Forget about CAM, that was not very useful. But siRNA was very useful. You see here the reduction of S antigen levels in all the categories, up to 2 log decline by week 24. But after week 24, there's a flat pattern. Even if you continue siRNA, there is no more decline. That's the first problem. The second problem, when you stop the drug after week 48, you have a rebound of S antigen. So it's not long-standing effect. The most important point, however, is on yellow on the lower right side. Not a single patient became S antigen negative, not even during therapy, not even off therapy. So yes, it's very good to reduce S antigen. No, it's not good, it's not enough to achieve functional cure by itself. Well, why don't we combine siRNA plus NUC plus PEG interferon? Well, we have used PEG interferon for 30 years, for B, for C, for Delta. Why not? We know PEG interferon is working, but maybe in combination we'll do even better. So there will be a triple drug combination. We do have a study. Yes, we do have a study. This has been presented, a few months ago at the American meeting. New data will be presented in a couple of weeks at EASL. So these are only NUC-suppressed patients, and they receive different strategies. In orange, siRNA monotherapy. You see, lower part, no S antigen loss, as expected. 2 log decline, but no S antigen loss. It's not enough. But in the kind of white-blue group, number 5, they got siRNA on the top of a NUC plus PEG interferon for 1 year. You see, right-hand side, 31% of S antigen loss. The best ever functional, it's not functional cure because it's on therapy. The first ever or the best ever S antigen loss rate in any trial in hepatitis B in the last 35 years. However, is on therapy, is not off therapy. And then you're using interferon with all the side effects that someone mentioned before. And you don't have the interferon monotherapy control group. So be careful. Very interesting, but we need off-therapy data. Well, why don't we try to stop antigen production by another approach, which is similar to siRNA, but is not completely identical, antisense oligo. And this is a drug from GSK, GSK 836, that was the old name of the drug, and this is a phase 2A study. Top left, you see the mechanism of action is similar to the siRNA. You target all the RNAs from the virus, but the mechanism is kind of different. And you see in these 2-1 studies, 300 milligram sub-Q injections once a week, 4 weeks, lower part, 4 logs reduction of S, 4 logs in 28 days. Never seen anything like this, but not in all patients. You see, some of the patients did not respond, some did very well. So because of this data, they ran a large phase 2b study, what we call the B-Clear study, recently published on the New England Journal of Medicine. It's the first ever study with antisense oligo in HBV. A large study, more than 400 patients, 24-week therapy. Please consider only the orange bar, which is 300 milligram once a week for 24 weeks, and then 24 weeks of follow-up. NUC-naive, NUC-suppressed, a large study. And these are the most important data from the New England Journal of Medicine. So these are S antigen levels on the left and ALT levels on the right-hand side during bepi, that's the name of the drug, bepi, 300 milligram a week for 24 weeks, and then 24 weeks follow-up. In 68 patients, NUC-suppressed, so it's an add-on strategy for 24 weeks. Let's start from the left part, and please consider only the green bars only. Those are S antigen negative patients. You see from the left to the right, for the first 24 weeks on therapy, there's a progressive increase of the proportion of patients achieving S antigen loss, up to 26% at week 24. The best ever drug, best ever response without interferon the last 35 years. But then you stop the drug, and the 26% goes down to 12%. So we have a major problem. It's not sustained off therapy. We have to do something about the drug to increase the durability of response. On the right-hand side, you see LT levels. You see that they're NUC-suppressed at baseline, so almost normal LT. But look at the yellow bar. The yellow bar actually is expanding. Yellow means abnormal LT. They started with normal. They give the drug, ALT increases. And the kinetics is different. You see the maximum ALT increase is at week 8. The maximum S antigen loss is at week 24. So S antigen loss is driven by LT levels increase, which could be a problem, could be problematic in some patients. Well, then in this study, they look at trying to understand why there are so few patients doing very well. Top right, that's the answer. The baseline S antigen levels are the most important, is the most important variable to identify responders. Top right, if you have an S antigen levels below 3 logs, 1,000, below 3,000, 22% of responders will respond off therapy for S antigen loss. So much better. Safety. Left part, the NUC-suppressed study, no major problems. For 24 weeks, 300 milligram, right inside the NUC-naive patients as a monotherapy without NUC. Same as antigen loss rate, but you see 2 patients at the major ALT flare. 2 patients at almost a liver failure. And that's probably one reason why this drug is in phase 3, but only in NUC-suppressed, not in NUC-naive. And this is the first new phase 3 study after 20 years in hepatitis B. It's running already Italy, Europe, and many other countries. That's probably very, very super important. So how does this drug work? On the left side, you see a graph where we plot the S antigen decline and ALT increase. They're strong correlation. So the more you have an increase of LT, the more S antigen decline. On the right-hand side, the S antigen decline was associated to cytokines. So why cytokines? This drug should go into the hepatocytes. Actually, 70% of the drug is not going to the hepatocytes, but is going to Kupffer cells because it's not GalNAc conjugated. So actually, it's working mainly as an immunomodulator and not a pure antiviral. That's probably the reason why it's working. Well, what we are expecting in the phase 3, you can do some modeling according to the data, antigen levels. You look at the red sort of squares. We are expecting in the phase 3, in selected population, 45% S antigen loss on therapy and 20% S antigen loss off therapy, possibly a real functional cure. We'll see in a couple of years. What about immunomodulation? Well, we have PEG interferon. We don't want to use the PEG interferon forever. Side effects, complications, and so on and so. Well, again, there are many drugs, many companies working on so-called immunotherapeutics or immunotherapeutic target. This is a summary, very nice summary, recently published on the New England Journal of Medicine. You have, checkpoint inhibitors, monoclonal antibodies, therapeutic vaccination, some toll-like 7-8 receptor agonists. So there's a huge amount of drugs, but to make a very long story very short, these studies did not show a significant S antigen decline, did not show any S antigen loss. So these drugs are not enough as a monotherapy, and new combinations are under development. So in summary, ladies and gentlemen, so we do have a new goal for hepatitis B. Is not DNA suppression, is cure. Cure means S antigen loss off therapy, which means what we call now functional cure. Remember, is a very fancy new name for a very old endpoint. So many drugs have shown significant S antigen decline, 2 or 3 logs even, for the first time. However, only 2 drugs showed S antigen loss at the end of therapy, antisense oligo as a monotherapy, which we call bepi, for 24 weeks, 300 milligram, or the triple combination of new PEG interferon and siRNA. However, only 1 drug so far showed S antigen loss of therapy, bepi, between 12 to 14% of the patients, both E antigen negative NUC-suppressed or NUC-naive patients. And there is only 1 phase 3 ongoing study, again, with bepi, but only in NUC-suppressed patients and only in NUC-suppressed with S antigen levels below 3 logs. So it's a very selected population. Many compounds have been discontinued because of safety issues, so we have to be very careful, and many compounds also because of no response. But there are many new combinations in the future, so I'm kind of optimistic that in the next 5 years, we will be able to achieve functional cure, at least in some of the patients. Thank you very much for your attention.